here.
Oops.
Hi, everyone. As you're joining the call, we're going to give it another minute or two so that folks who are coming from another Zoom have time to join us. Good morning, good afternoon, everyone. I'm Ken Mayer from the Harvard University Center for AIDS Research. On behalf of my co-convener, Patrick Sullivan of the Emory CFAR, I want to welcome you to the Antiretroviral for Prevention Working Group seminar series. As most of you are familiar, we're trying to do this every other month. Just a plug for the series. We welcome your suggestions about speakers who might be covering topics that are of particular interest. We're always trying to feature the most cutting edge science and want to showcase important work going on at some of the different academic centers around the country, and also want to stimulate some discussion. So we will have some time for Q&A at the end. Because of the way this webinar is set up, we appreciate if you put your questions in the chat, and Patrick will be culling that information, and then we'll be able to have a robust Q&A at the end. So it's really great pleasure that I have today to introduce two very esteemed colleagues, Christina Saros, who's an associate professor in the Department of Psychiatry at Harvard Medical School and the associate director of the Behavioral Health Program at Massachusetts General Hospital, and a colleague and collaborator at Fenway Health, in addition to her many other collaborations, both in the US and internationally. And with her presenting is Steve Safran, who is a professor at the University of Miami, a Cooper Fellow. He's also the director of the CHARM program, Center for HIV and Research and something. Steve, you'll remind me about the acronym. But at any rate, Dr. Safran has led national and international protocols focusing on biobehavioral aspects of HIV treatment and HIV prevention. So they're going to be discussing an intervention that they've developed called Life Steps for Prevention Adherence Counseling and their development, outcomes, and application. So Steve and Christina, please take it away. Thank you.
Awesome. Thank you so much. And we're going to be going back and forth between the two of us. A few slides me, a few slides Christina. But thank you guys for inviting us to give this talk. I'm going first. If you can notice on the bottom, we have pictures of each of us in case you're wondering which one of us is Steve and which one of us is Christina. So I wanted to clear up that confusion at the beginning. And also, you know, Ken didn't mention, but I've worked at Fenway Health for, you know, basically my whole career in some capacity, even after I moved to Miami 6 years ago. So it's a nice continued collaboration with, excuse me, Fenway and the Harvard CFAR to be able to participate today. So we're talking about life steps for prevention, adherence counseling, development, outcome, and application. These are my disclosures. So mostly all royalties from books on cognitive behavioral therapy, which I'll be talking a little bit about cognitive behavioral therapy today, because that's the basis for life steps adherence counseling. Here's just a quick outline of what we'll be going over. First, the development of the intervention, which started off for HIV treatment, and then we've adapted it for prevention using first antiretrovirals for prevention in serodiscordant couples, even giving it to the infected partner in the 052 trial, and then then with PrEP as the second set of studies that we'll be discussing. So what is Life Steps? As I mentioned, it's based on something called cognitive behavioral therapy. Cognitive behavioral therapy is a type of psychosocial treatment, like a therapy, different than traditional psychotherapy in that it involves learning skills about how you think about things. So that's the cognitive part. What you do, that's the behavioral part. And a big component is also in the way that we've done it is we've combined it with motivational interviewing, which is a technique that is non-judgmental. And it's to ask people questions and get them to try to resolve ambivalence that they have about change. Recently, actually, motivational interviewing has been in the news. I was watching MSNBC last night. They had someone talking about it for vaccine hesitancy as a way to try to convince people to resolve their ambivalence about wanting the vaccine. So the technique has been around for a while and tested in numerous randomized trials as a way to get people to kind of not necessarily, it isn't really supposed to be convincing people to do things, but it's more to help them resolve ambivalence about change and draw out their own internal motivations for wanting to change and trying to highlight that and then move them in that direction. And then the biggest part of Life Steps is helping people solve problems more effectively. So it's a step-by-step approach, breaking things into manageable steps. And when we first developed it, it was a single counseling session for HIV treatment adherence. We've now expanded it. We've used it in HIV and diabetes and oral chemotherapy for cancer. In the US, there's several domestic trials where we integrate it with mental health treatment and substance use treatment. There's been studies, there's ongoing studies in places like China, New Mexico, Zimbabwe, Uganda, South Africa, Eastern Europe. And it's picked up. The little brochure right there, if you can see my pointer, is the version that's used in South Africa by Doctors Without Borders in HIV clinics. We also used it in the ACTG 5175 trial and the HPTN 052 trial. These two studies were large scale network, NIAID network, one obviously ACTG, the other HPTN funded studies, and started off as sister studies with similar assessments and similar adherence counseling components, again, based on Life Steps. One interesting finding from those trials, both were successful. HPTN 052, as people probably know, most relevant to this talk, was the definitive trial that showed that HIV would not be transmitted in serodiscordant couples if the infected partner is on antiretroviral therapy and has a suppressed viral load. Interestingly, in the two different studies, there were different predictors of better adherence or worse adherence. I guess in the treatment study, which was the ACTG trial, the more complicated regimens and worse perceived health and higher drug use were predictors. But in HPTN, across all the different predictors that we put, the only predictor of non-adherence for taking antiretroviral therapy, mainly as prevention, because in that trial, treatment guidelines were that you wouldn't start antiretroviral therapy until you reach clinical need. The only predictor was worse mental health. And those questions were mostly regarding depression. So what is involved in the Life Steps intervention? Like I said, it's different steps to break down the task of taking medications as prescribed. And in when we first started with Life Steps is right when antiretroviral therapy or highly active antiretroviral therapy became a thing. And at that point, as people might recall, taking medicines for HIV was really difficult. The regimens were really complicated. Sometimes you had to have food, sometimes you didn't. One dose might involve like taking certain pills without food, waiting an hour, keeping things refrigerated, then taking other medicines with only fatty food. Like it was like a full-time job just to stay on those new life-saving, at that point, new, but also life-saving medicines. So what we tried to do is just break it down into manageable steps, such as First, enhancing motivation and providing the information about resistance and things like that. And then for each of these steps, like getting to appointments, side effects, communicating with the treatment team, formulating a schedule, storage, each of the things that were needed, having a plan and a backup plan that the person would, once their motivation was increased and they resolved their ambivalence about changing through our non-judgmental counseling, once that happened, then we would proceed to try to come up with a plan and a backup plan to make it as easy as possible. So like I said, we made a little method here. We called it AIM, where first you articulate the problem, you identify the barriers, and then you make a plan and a backup plan. This slide I got from Ken Mayer, the fabulous Ken Mayer, who introduced us, but it's not very recent, but it was, the first kind of summary of the different trials of PrEP efficacy studies, and really finding that as adherence increased in the trial, so did trial efficacy. And we now know since then that 4 doses a week basically keeps you protected if you're taking PrEP orally from, if you're taking PrEP and you're trying to get protection from condomless anal intercourse. And so I'm going to turn it over to Christina now to talk for a little bit.
Thanks so much, Steve. And thanks again to everybody for having us. It's a pleasure to be with you this afternoon or morning or whatever time of day you might find yourself. So I'll just talk a little bit about Steve and I, the work we did for the Partners PrEP study. So this was what feels like a century ago, but not all that many years. But the Partners PrEP study was really our first attempt to take the LifeSteps intervention that was developed for HIV care and adapt it to the needs of persons who wanted to use biomedical prevention. So as everyone likely knows, the Partners PrEP study was a phase 3 double-blind, 3-armed randomized trial of daily oral PrEP among serodiscordant heterosexual couples in Africa. There was an ancillary adherence study that was led by David Bangsberg and Jessica Haberer, and Steve and I were brought in at that level to develop an adherence support intervention. The study ended early after the DSMB recommended that all trial participants be offered active drug due to efficacy. I will now talk a little bit about our specific work with the ancillary adherence study. So as part of our goals here, the larger adherence study was really trying to understand patterns of adherence among trial participants. And the cohort of individuals in the ancillary study consisted of 1,147 individuals with pretty high adherence and 100% PrEP efficacy among that cohort. And it's among that cohort that Steve and I implemented LifeSteps. So our goal was really to develop and deliver an intervention that would support trial outcomes. We were focusing on participants that had documented lower levels of adherence. And at that time, it was less than 80% adherence to their oral study product based on unannounced pill count. We didn't know quite how LifeSteps would need to be adapted for PrEP users at that time, particularly in the African context among heterosexual couples. So we traveled down to the study sites and conducted some informal focus groups. That work was unfortunately interrupted due to some civil unrest, but we were able to meet with a few groups of people and try to understand, again, how we might need to modify LifeSteps to fit the needs of these participants in this particular trial setting. So we developed an adherence intervention, and then we got ongoing feedback from the sites and the counselors on the intervention and how it was working for them. We trained the interventionists over a 2-day period in person, back when we used to do in-person things and travel. And then all interventionists participated in monthly supervision calls and at least a yearly site visit with either Steve or I to talk about cases and provide support and supervision. Knowing that the intervention would be developed by lay counselors, we really tried to think about how we could take this evidence-based intervention that had been developed and delivered by a lot of psychologists and make it kind of executable, if you will, by laypersons. So we tried to really standardize our messages and came up with a checklist of topics to be covered at each session, and basically created a written manual that the interventionists could use to guide their sessions and also take notes to help them remember what transpired from one session to the next and keep a record of things they discussed with their clients or their participants. Once the intervention was triggered, so once someone was noted to have adherence less than 80% by unannounced pill count, counseling occurred kind of in two phases. So the first phase was with the individual who was using PrEP, and they could have up to monthly contact with the interventionist, but also the interventionist and the participant could decide how much contact was really necessary with respect to adherence counseling. So it was very flexible, very client-centered. There was a lot of choice in terms of frequency of meeting. The second phase was to allow for a meeting to be held with the partner who was living with HIV. And this was purely optional. But one of the things that we learned when we did our kind of informal formative work was that the kind of partnership could be really important, both with respect to creating barriers to adherence, but also creating facilitators to support adherence. So we developed an optional partner session as well. And we set it up such that the participant who was using PrEP kind of had full control, was in the driver's seat in terms of what information would be shared with the partner, what was safe, what wasn't safe, and just created a space where the couple could come together and potentially find ways to support one another. So we collected some data. So this wasn't testing the outcome of the intervention, was not a primary aim of this ancillary adherence study, but we did collect some data and try to make sense of what happened. So one of the questions I think Steve and I always get is, this intervention sounds really nice, but how long is it going to take? And what's realistic in a busy clinic setting or even a busy clinical trial setting? So we did collect some data on how long the sessions ran, and the average session was about a half hour. On average, participants completed 6.8 sessions. And I will say, though, that it's, I won't say that that's what was necessary, but that's what people opted into. So I think some participants liked the intervention and kind of wanted to meet more regularly. And we asked people about the things that got in the way of their PrEP use, and travel and forgetting kind of topped the list. And it's important to remember that, many of our participants lived in rather rural settings and would, travel to visit family for funerals, for work, et cetera. And so there was a lot of travel going on, and sometimes people were away for longer than they anticipated, or forgot to take medication with them, or had stigma or privacy concerns while they were away that precluded them from taking their medication. So with respect to what we saw, the average adherence at the time of trigger for our participants was around 65%, and we saw a significant bump in adherence after the first session, and that's what's reflected in the box at the top of the slide. The graph at the bottom of the slide shows adherence over time, and you'll see that there was a steady decline, a slow decline in adherence over time. That decline was less for participants that participated in a greater number of sessions, but I think does kind of raise the question of kind of how much counseling is enough, and how often do we need to meet with people in order for the counseling to confer benefit.
Okay, so back over to me. Thank you. And one thing, so that trial was the first time that we used LifeSteps adherence counseling for PrEP. And as Christina was saying, it wasn't a randomized trial, but the way that it was set up was that we kind of swooped in once poor adherence was detected through the monitoring, and tried to keep people above 80%. And, as she also mentioned, that strategy of monitoring plus swooping in got 100% efficacy in the ancillary adherence trial for PrEP. There were no infections in people that were in the group that got that package, but there wasn't a control group. So the first study that did a randomized trial of LifeSteps for PrEP versus treatment is this R34 funded study, also from Gilead Sciences, who donated Truvada. Ken Mayer and I were or Ken was the PI of it. I was a co-PI. And it is now, even though this was a pilot study, there are very few, I think there's 2 randomized trials of PrEP adherence interventions that CDC has designated as being emerging evidence-based. So if you want more information, there's the link there, and I can provide the manual. The way that the study was set up is we did data collection through WisePill, which is like the MEMSCAP that Christina was talking about, but it does real-time signals when it opens and closes, as well as self-report. And then we also assess daily sexual risk with an SMS survey and also computerized assessment when people came in for study visits. The intervention, in this case, we made it more standardized. So it was 4 adherence counseling sessions and then 2 booster sessions. Similar an approach, cognitive behavioral based. It was delivered by nurses. And yeah, I mentioned the approach was similar in terms of the theoretical background. The control condition. So in this study, we had a very rigorous design, and I think actually too rigorous when you'll see the results, in that the control condition also got the same amount of counseling, but it was more informational and supportive than the specific modules of Life Steps. But, you know, dealing with things like sexual health, nutrition, exercise, behavioral health, substance use, and sleep hygiene. So, you know, it is tough in these prevention trials when you do these rigorous designs where someone's getting counseling, even if it's not directly PrEP adherence counseling. It's hard to show a difference between 2 arms on a health behavior when someone knows that the inclusion criteria is being on PrEP and newly prescribed PrEP, and, you know, it's a PrEP study. And even though the counseling might not directly being addressing, you know, barriers to PrEP, you are coming in and kind of talking about health. Anyway, so it was a small trial. We randomized 50 people to either the cognitive behavioral Life Steps intervention or the information and supportive psychotherapy. 11 people were lost to follow-up across the 2 arms. Adherence, there was not a difference on the WisePill adherence between the 2 arms, although the CBT condition did have some higher adherence in terms of like percentage points. But, you know, it was a small study with the rigorous control group. So, you know, it was designed not to test efficacy, but more feasibility and acceptability. We did, however, find in our intent to treat analysis, we did find differences across the 2 conditions in terms of our blood levels of tenofovir, and showing that there was a favorability to the treatment condition for the Life Steps condition to be more likely to take PrEP every day. And that was before the data came out that you only need to take it 4 days a week. So that was our planned analysis. We are now testing this in an R01, a much larger study, which started recruitment right when COVID happened. So we're eking along in terms of trying to get people in. Unfortunately, there are fewer PrEP starts happening in Boston and Miami, as people, for a while, the clinics were closed. So it was, it's been a little bit challenging, but we are, specifically, the new design is a little different in that it's a stepped care design where everybody who gets randomized to the intervention gets text messages. Oh, in our prior study, everyone was getting text messages for the sex surveys. And that also people would say like, oh yeah, whenever I got the text message about, you know, whether I had sex or not, that reminded me to take my pills. So I did. So that was another thing that where I think adherence was high in both conditions in that prior study. But here, everyone gets the text messaging if you get assigned to the intervention condition. And then if you continue to have adherence problems, kind of like the trial that Christina was talking about, where you don't take your PrEP as prescribed, then you are step up to get the Life Steps adherence counseling. And then to be able to do a cost effectiveness analysis where you're having the control group not be a time matched, attention matched control, but instead be treatment as usual. And also to try to get people that need it the most in terms of preserving resources. Not only are we doing the step care approach to try to just do a minimal, very inexpensive intervention for everybody, but also to screen in to this trial, you have to have either depression, heavy alcohol use, problematic substance use, or history of trauma, all kinds of risk factors for potential non-adherence. Oh, and we also, this is just a picture of a couple of the modules from the flipbook. As we're also focusing in interventions in general in the field of behavioral medicine and psychotherapy and cognitive behavioral therapy, there's a real need to disseminate interventions in ways that don't take a ton of training and don't take a ton of supervision, but have it be that counselors can do an intervention without kind of slipping into, or drifting, we call it, into just open-ended counseling, but instead sticking to the actual intervention content. And so we've taken a cue from other researchers to make this into more of like a flip book that you go through with the participant, counselor and participant together, almost like you're going through a self-help book and you're talking about each page as you go along. And we found that it really helps stay on topic and make it, you know, that the actual content is more likely to be delivered. So we've used this flip book approach now in our current R01 and also the trial that the two trials that Christina's about to talk about.
Thank you, Steve. So moving on to talking about one of our other current projects, and a project on which I'm lucky enough to collaborate, or Steve and I are lucky enough to collaborate with Patrick and Ken on, is looking at how we might modify the Life Steps intervention for youth who are interested in using PrEP. And so this study is ETN 158, or Life Steps for PrEP for youth. And we're currently funded to conduct this trial, where aim 1 was to use qualitative methods to explore the ways in which Life Steps would need to be adapted for youth. And in this case, we're looking at young men who have sex with men. And then to conduct a pilot 2-arm RCT of the modified Life Steps intervention with the primary outcomes of feasibility, acceptability, and an estimate of preliminary efficacy. So our qualitative study is done, and we conducted some qualitative interviews with young men and also a few key informants, healthcare providers, and community stakeholders to really understand what are the challenges that may get in the way of young men using PrEP effectively. Sorry, Steve, now you can change it. So just very briefly to provide an overview of those qualitative findings, I think it will come as a surprise to no one that both the young men and the healthcare providers reference stigma as an important barrier to be overcome with respect to effective PrEP use for this population. The young people in particular were worried about how they might be negatively labeled as being promiscuous with respect to PrEP use, and had a lot of questions about when it's appropriate to disclose PrEP use to partners, to healthcare providers, to friends and family members, and how to disclose when they wanted to disclose. Another barrier that came up for this population is kind of still being on parents' health insurance plans and wanting to keep PrEP use private, and fear of inadvertent disclosure, both of sexual orientation and PrEP use. Challenges with planning ahead and just kind of having to do something like take a medication every day were also described by both groups of participants. Some of the young people noted that, they didn't have practice taking a daily daily medication before, and so they anticipated that it could be a challenge versus adults or older people may have had that practice. We also asked participants, the young men, to share with us, what type of provider they might want to meet with. And things that emerged here were a balance, identifying someone who was perceived as an expert. So participants reported being very comfortable with nurses, but also making sure that whoever met with them to talk about adherence could create a very comfortable, non-judgmental environment and truly kind of understood the context in which they might want to use PrEP and were just kind of hip to issues of young people, et cetera. And then lastly, the young men reported that the sex ed that they received in school was woefully inadequate, and that they often had to kind of find out information for themselves. And wouldn't it be great if they could have a trusted source of information to kind of get the information that in many cases, schools were not providing for them. So I included just a couple illustrative quotes here. So this participant here, again, talks to the point I just made earlier that, not having experience taking a daily medication, that might be one way in which they're different than adults, and kind of needing to set up systems and to kind of get used to that process. And then this is a quote, I think, illustrating, again, kind of this absence of education and knowledge being provided in any systematic or trusted way, and sometimes needing to learn things the hard way or by trial and error versus kind of being taught. So we summarized these data and made a few key modifications to the LifeSteps intervention that is now currently being tested in our RCT. So we expanded and added and expanded content on kind of general sexual health, or kind of sex ed 101. We added key content around thinking through, when you might want to disclose your PrEP use, and if you, thinking through the pros and cons of a PrEP use disclosure, and then trying to give participants tools to make an effective disclosure. And then we added some kind of problem-solving material around managing privacy, and also enhanced the PrEP payment concerns content for the intervention. So this is what the RCT looks like. We will likely close enrollment this fall, and look forward to presenting results to you shortly thereafter. But it just shows participants are randomized to the intervention or standard of care, and we collect DBS data from them to try to create an estimate of preliminary efficacy of the intervention. But again, primary outcomes are feasibility and acceptability.
Okay, and then another place where we've used LifeSteps for PrEP is the HPTN 083 trial, which was one of the huge breakthroughs in HIV prevention recently, using injectable PrEP, showing not only non-inferiority, which is how the trial was designed, but also actually showing superiority. And we were challenged. The schematic of the trial below is a little bit, I find always confusing whenever I look at it, but basically everyone in the trial, regardless of whether they got randomized to saline or injectable PrEP, had to take either cabotegravir or Truvada in a run-in period orally. And then if they were on cabotegravir, they got randomized to injectable cabotegravir. If they were on Truvada, they continued to take Truvada, but with injectable saline. So everyone was taking pills throughout the entire time that they were in the study. And we were tasked with something that we found very difficult and challenging, which is we needed to provide standard of care adherence counseling as best as we could, but we couldn't make the adherence too good, because if adherence was better than, say, how the study was powered, which was based on the IPREX trial, If adherence was too good, then it would be a much harder comparison to show non-inferiority of injectable, because the whole point of injectable was to try to deal with the adherence issue in orals. So, so we had our hands tied a little bit, but we still, I'd say, tried to develop something that would be as best as it could be. And also, given that this study was done in so many different countries and so many different settings, resource poor settings, difficulties with clinic time and availability of counselor, and, you know, really wanting to make an intervention that, you know, maximizes the potential of adherence, but also, you know, acknowledges that there are limitations of oral PrEP, and want to be able to show differences, if there are any, or superior or non-differences, I guess, in injectables. We also did a flip book approach. We had different ways of doing this where everybody got a certain level of counseling, which really did take, I'd say, about 10 minutes or so. But then people that seemed like they were having additional problems would have additional optional modules. And all of it was similar to the Life Steps approach that we were talking about before. A secondary finding, this is about to come out in, the main finding was presented at IAS, and not this past IAS, but the one before. And it's about the paper is about to come out. If it hasn't come out like today, it's going to be very soon in New England Journal of Medicine, showing superiority of cabotegravir injectable over Truvada, but oral Truvada, that is. But we found really high, that finding happened in the context of quite high adherence. As you see, pill count adherence was 96% for both study arms. And then there was a randomly selected subset of 390 people in the Truvada arm with 74% consistent with, oops, sorry, my screen is messed up here, with daily dosing, 86% above the lower limit of quantification, and 72% within the past month. So that's why the percentages are a little different, approximately greater than 4 doses per week showing coverage. Christina, back to you.
Thank you. So we were fortunate enough in 083 to develop a qualitative sub-study to try to kind of understand participants' experiences in the trial, how they experienced injectable PrEP, and to think a little bit about barriers and facilitators to adherence. So we designed a qualitative sub-study and proceeded to collect data. In March of 2020, we stopped interviews due to the onset of the COVID-19 pandemic. And then 2 months later, the DSMB recommended unblinding. So we stopped the first phase of our qualitative research. We have since regrouped and initiated a new-ish, same protocol, but new revised aims for the qualitative sub-study. And we are essentially collecting data related to product preferences and preferences around implementation from participants once they have made a choice about what study product they would like to use in the open label extension phase of the study. So I have a little bit of our qualitative data from the first part of our qualitative study to share with you today. And this was also presented at IAS last month. So participants that took part in our qualitative study, you can see hovered around 26 years old. Most of them identified as cisgender men, and about 66% of them identified as Black or African American. We collected data, sorry, I meant to mention this earlier, but for the qualitative sub-study, we are collecting data at 5 sites. So we have a site in Thailand, in South Africa, in Brazil, and Chicago and Atlanta. And the data that we are presenting today came from Chicago, Atlanta, and Brazil. The other 2 sites are participating in the second phase, but we do not have data for them for this first round of data. So when we asked participants what motivated them to participate in HBTN 083 and to use PrEP, there was an overwhelming sense of a desire to prevent versus treating an illness, and that prevention was a much better option than treatment. Participants were drawn to the opportunity to have access to a novel biomedical HIV prevention product, and also noted that they found the idea of an injection to be highly convenient. And I think what was interesting to me is participants were also drawn to the study because they really viewed this as a means to enhance their own health via more frequent health screenings provided by the study, but also to contribute to their community and to contribute to the HIV prevention efforts within their community, and to really kind of be a part of that and drive change. And there are two quotes here illustrating this concept that prevention is better than treatment. And then the second quote here among one of our transgender women participants was around how the study afforded her the opportunity to access medical care that she may not have been able to access otherwise in the form of gender affirming hormone treatment. With respect to how participants viewed the study and their experiences and things that they found helpful, the sites were incredibly accommodating around scheduling flexibility and offered visits at times that really fit into the participants' lives. So this wasn't just a 9 to 5 show in many cases, and participants really, really appreciated that and felt like it reflected congruence with the reality that is their lives, that it's sometimes very difficult for them to get to clinic at a pre-specified time or during this kind of 9 to 5 work day. Participants also described frequent and thorough communication from the sites in a real open and affirming staff and environment. And for many participants, this was not the norm, and this reflected a radical departure from a lot of the medical care they had received outside of the context of the trial. This quote here, I think, highlights this open, affirming, and non-judgmental attitude. This participant wanted PrEP and had an experience where when asking a provider for PrEP, there were a lot of follow-up questions about why do you need this? What behaviors are you engaging in that would require this? And at the study, it's just, you want PrEP? Sure, we can do that for you, without a lot of questions that were perceived as negative and potentially shaming. When asked specifically about how they felt about injections, participants described the injectable PrEP experience as an easy-to-use product with minimal discomfort. Of the participants who did mention side effects or injection site reactions, they were described as mild to moderate, and participants came up with strategies to manage them, like avoiding rigorous exercise a day or two after the injection, relaxation, massage, etc. Some participants described some anxiety around their first injection and not knowing what to expect, but that this dissipated over time and did not serve as a barrier to subsequent injections. And then lastly, we did pick up there were some kind of concerns and a little bit of potential misinformation around how injectable PrEP worked. So a participant comes to mind who felt that injections should be more frequent and had a fear that they would wear off. And another concern was, no biomedical HIV prevention product will protect you if you're having a lot of partners, and that the more partners you have, the product does not work as well. There's one quote here, sorry, Steve, but one quote on the previous slide that highlights, I think, a different anxiety experience. And there was a participant for whom the first injection experience triggered memories of sexual assault. One of our, I think that kind of helps us think through checking in with participants about any fears or concerns they have, particularly around those first few injections. Facilitators and barriers to getting to study appointments for oral product or injection were essentially the same, and kind of nothing particularly novel emerged here. But I do think this quote really does nicely capture the reality of participants' lives, very busy and sometimes needing to make choices about what they prioritize. And in some cases, that just couldn't be the study or their injection visit or their oral product adherence. So in summary, what we learned, the study was viewed as a very positive experience and a means to not only take care of themselves, but also contribute to their community. And participants were drawn to the ability to access this novel biomedical HIV prevention product at no cost. With respect to implementation, we may have to kind of challenge some of these paradigms of how medical care is sometimes delivered, and think about what we can provide in terms of one-stop shopping and whole body screenings, ensuring open and affirming staff and staff that are willing to kind of build relationships with participants or clients over time, flexible visit schedules. Providers might want to remain aware of anxiety that participants may have around injections, and potential trauma history. And we should also be aware that our patients, clients, participants may have varying degrees of understanding of how these products work, and we should listen for misinformation and correct it. Anxiety decreased over time in terms of anticipatory injection anxiety, and didn't seem to be a big barrier, at least among the people that we spoke to. For participants, remuneration was important and viewed as a key benefit. So we also need to be mindful of how participants, clients, patients are going to pay for PrEP and support them in negotiating those avenues.
Yeah, so those are the major content slides that we had. In terms of just overall conclusions, the intervention that we talked about, we have adapted it and to a variety of settings and PrEP needing populations, both domestically and globally. So far, it appears to be useful across the different trials. Next steps, as I mentioned, we're doing the randomized efficacy effectiveness trials. We want to look at the level of intervention that's required for, really optimizing prevention, effective adherence, and persistence. And I think, our stepped care design will help answer that a little bit. We need to look at implementation science and also cost effectiveness. Thank you to many collaborators from both of us, including but not limited to, as I say here, but Ken Mayer has been a lifelong, career-long collaborator and friend of mine. So shout out special to the amazing Ken Mayer. Rafi Landovitz was the PI of is the PI of HPTN 083, Jessica Haber and David Bangsberg with the Uganda trials. And these are the funders. And thank you to the study volunteers. But we can now turn it over to Patrick to ask us the Q&A. I see one question that I'm sure me and Christina are very excited to answer.
Yeah, so first, if you want to use your reactions or unmute, and for those to express our appreciation for just a really great presentation that started out with the foundations and just shown all the potential and how you've used this in different settings and been rigorous at each step. So congratulations and thank you so much for the talk. And I think actually between your last slide and what I've been thinking about and what Joanna's raised, I think we have time for a nice discussion here about implementation and sort of the future direction. So I'm going to start out for those who don't have their chat open by just reading Joanne Steckler's question, which I appreciate, which is, it sort of has a couple parts. So thanks so much for the information. I worry that we're going to end up at the same place with behavioral interventions that take burdensome amounts of time over multiple sessions. We have heard from providers that they're willing to do interventions that take 5 to 10 minutes. So I think this is partly, or wholly an implementation question. So who will the implementers be? And I guess you could take that from a couple of perspectives. One is, can you make this a short one-time intervention? Are there components like maybe for people who have a lower level of need? Or who are the interventionists and how do you see that being implemented? And again, you've done this all over the world. What are the considerations maybe? And that's for either or both of you.
Yeah, I have a lot of thoughts about this, and a few things. One thing is just that behavior change is so hard, and we are smacked in the face with that all the time. When we see all the stuff about COVID and masking and vaccine hesitancy, that's just currently what we're seeing with how hard it is to get people to change behavior. But even if people who are thinking about this or asking these questions, like even think about your own behavior and how hard it is to like, you know, oh, I'm going to start exercising for the 15th time, or I'm going to start like dieting or quit smoking or, you know, reduce drinking. Like these are really, really hard things to get people to change to do. And so, yeah, some people might benefit from a lower level intervention and other people won't. And, you know, we really like the thing about a 5 to 10 minute intervention, like over the years, both Christina and I have been invited to collaborate with, you know, small and large scale studies where that is the basis. It's like, and even in this study in OA3, like we have to kind of battle a little bit about it. But, you know, we're invited, like we consulted in Voice halfway through, and also IPREX, you know, where it was like, okay, you know, we're halfway done with the trial. We need to really think about adherence now. And you know, we need the intervention to be 5 minutes. And, you know, like I remember saying, like, I don't think that that's going to be, you know, fruitful. We need to really think about what's going to be needed. And, you know, the direction that they went in is, you know, you see the results of the studies where Voice, you know, wasn't a positive trial, and IPREX, you know, luckily was, but adherence was less than optimal. And, you know, there's also, you know, when you think of medical treatments, you know, you don't give people half of a dose of an antibiotic because they don't want to take it, or, you know, you know, chemotherapy is really burdensome, but it takes, you know, however many doses over however many weeks. So, you know, when you're really thinking about behavior change interventions, you have to think about it in the same way that you think about expensive medical treatments, that, you know, there is a cost. We're trying to look at cost effectiveness outcomes, and the ones that we are looking at in my studies are looking pretty good, but there is a cost and there is a dose that's needed. And I think the only way to be able to say, like, all right, well, let's do like these brief interventions or just messaging. Yeah, we can do that. I'd say for, you know, I don't know what percent, but let's just say like 1/3 of people might benefit from a 5 to 10 minute intervention. And then we need to kind of, I think, identify who's going to need, you know, more than messaging or more than the app or more than the brief thing, and target those individuals. And that's why we're trying to do some of these more stepped care approaches where like everybody gets text messaging, but then those who are still having problems or those that also have depression or substance use, like step up to a bit more, knowing what the whole, you know, years and years of evidence base exists for psychotherapies for substance use or psychotherapies for, you know, depression, and how intensive those treatments have to be to get the outcomes that are needed. So I think like the cost benefit of the dose or how much time is really going to be directly impacted with, you know, both the impact that you can make and then also targeting who needs it the most.
And so actually, Christina, do you want to add to that? And then I'll further this conversation. But Christina, what would you like to add?
Sure. And I'll try not to, I agree with what Steve has said in terms of novel things to add. I would say I'm particularly interested in understanding kind of the range of providers that can be engaged in providing these counseling interventions, thinking about medical assistants and nurses. You know, I'm doing a PrEP uptake project in rural Alabama, and it's a real, I mean, understandably, resources are a real consideration. And, you know, we're having a hard time finding ways for providers to have a 10 to 15 minute conversation with at-risk women about PrEP uptake. But we're hearing from the women, they really need at least 15 minutes of their time to make an informed decision. So it is a really tricky balance. And I appreciate that and hear the comment. Other than that, I think I agree with everything that Steve has said. To allow Patrick to further our discussion, I'll stop for a minute.
Yeah, it just occurs to me that Joanne's point might be to the point of not telling the physicians prescribing the medication that this is like something that you need to do. But if there's evidence that that it actually ends up increasing the efficacy in preventing infections, then you might see places where, you know, the payers for the intervention are going to benefit from the cost savings, like in a Kaiser or in like these organizations where you can do the math and say like, well, if we invest in 2 or 3 of these counselors who can help the people who need it most, we actually may avert HIV infections that we would then have to pay to care for. And then the other thing I think that's always the discussion is, given that this is a pretty, that you need a skilled interventionist, is there an opportunity to have centers of excellence or to centralize this a little bit so that, Joanne, when she's seeing a patient, could sort of hand that off and say like, there's a resource that you can use for this. Maybe you teach the clinicians to screen for who might benefit based on what you found in all your studies are predictors, and then sort of think about that as an implementation approach.
Yeah, I agree. And I think particularly around, substance use and depressive symptoms that are clearly interfering with adherence behavior, in that case, I think, particularly in those cases, that's kind of beyond the scope of what the prescribing provider is able to do. And so I think, those are some of the barriers where it may be about linking that person to some effective substance use or mental health treatment at that point.
I mean, I think it's about like finding the right provider, but it's also about like who will pay for it, and how you put that whole package together so it's seamless. But you think about it from an implementation framework where the challenges with this may be either at the level of the individual provider or the organization. The providers because of their time pressures, and the organization because of space, or I don't know what the other like at those levels. But it does feel to me like it's a really ripe area for these kinds of questions. I'm gonna if anybody wants to raise your hand or jump in with a question, please do. If not, I have one more that we only have a couple minutes left, but I think I always struggle with these, this is such an amazing, platform and tool, and you've shown how you've sort of used it in a variety of different settings. And I guess I wonder what your thinking is about whether each new setting is an adaptation in the sense of like adapted or another framework followed by a trial to reprove efficacy. Or are you to the point now where you understand enough about the process that you could either wade in with a type 2 or a type 3 sort of hybrid implementation trial and say, we don't need the main thing to be efficacy anymore. We can sort of confirm efficacy while our primary focus is on implementation. So where do you see this, like, at what point, if any, do the RCTs of each adaptation stop, and do you start to move towards something that's a faster timeline and asking questions about the specific setting or population?
Yeah, I mean, good question. We're the first randomized study of this was the R34 that I presented. And then, and now we have the ATN trial that's emerging. And then, the more definitive trial that's powered for efficacy on adherence is the R01 that Ken and I are currently doing. But we don't, we were hoping to be able to test efficacy provided we can re-enroll now that, well, it was supposed to be that we were going to be opening back up, but now the Delta variant is with us, and we'll see what happens in the different clinics. But we do want to finish the efficacy trial that we planned, and then it would be good to look at implementation. And I don't think at this point, we would need to do a whole another efficacy trial in a new setting, because at least we have feasibility and acceptability and temporal changes in adherence in local settings. It would be nice to show efficacy. I hope that we can.
Yeah, and then but I think the variety of settings that you've really brought this forward in speaks to that, another range of implementation questions, and you might be able to build off that trial to do something that's more in the type 2, type 3 world. after it's established. So I just think it speaks to the breadth of impact that this could have, and then how you get there quickly. Follow up.
Thanks.
All right, I'll just ask Christina first, and then Steve, if you have a last word from all these discussions. We have a minute left. You have anything pithy for us?
That's a lot of pressure.
I know.
I don't think I have anything particularly pithy, but I really do welcome the comment about resources. And I just wanted to echo your sentiment, Patrick, that it is really, I think, identifying, demonstrating to payers the worth, and identifying people with maybe less specializations to kind of help us carry the torch here.
Thanks. Steve?
Yeah, I guess nothing new, but I would just repeat the message of how hard it is to change behavior. And, I mean, what we think about, the 90-90-90 goals that weren't quite where we wanted them to be, and now the 95-95-95, and then after that, eventual HIV eradication, in the absence of a cure, and even if there was a cure, we'd need probably people to change their behavior to do the cure, whatever that might be. There is a behavioral component of every medical treatment. And, some illnesses, I mean, HIV, a huge part of treatment is behavioral, is taking your pills every day. Diabetes, it's like, and also like 90% of diabetes care is self-care. And yet it, people really remain uncontrolled. So, we have our work cut out for us. And I think looking at these issues of like cost effectiveness, sorry, the other thing you mentioned was Kaiser, and a problem, since I have the floor and a soapbox in the last minute, but the problem with like a lot of US healthcare systems is that insurance companies aren't really that concerned about long-term prevention, because what happens is people switch their insurance companies so often. So like if I have, Aetna right now, I'll probably change. Well, I mean, I don't think I'm going to change my job, but like a lot of people change their jobs every like 5 years or something. So by the time the cost savings would kick in to a system, like that individual person that you've invested the prevention money in might be like is likely to be in a different insurance company. Whereas places like the VA systems, or, where it really is like a closed model, or countries that frankly have socialized medicine, like you can probably see the cost savings a lot more like in actual dollars, because people won't be switching around as much.
It's almost like we need a single payer system. So I'm gonna have that be, Steve's comment be the last word, with thanks to our hosts at the Harvard CFAR, to my co-host Ken, to our great presenters. I hope everybody has a good afternoon.
Thanks again for having us.
Bye.
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 Bye.